body in the UN system who is working on trying to provide support and guidance to states in moving forward and trying to take those principles into reality and policy is WHO. And MichelleFunk will guide us in the evolution of the work of WHO with regards to those issues.
Well, thank you very much, and thanks also to the organisers for inviting me to this conference. I suppose a lot of you have been waiting to hear what WHO has to say on this topic of community inclusion and independent living. There's been mention of WHO throughout the days of this conference, so I'm really happy to have the opportunity to enter into dialogue with you and to talk a little bit about what we're doing and some of the positions. So I've been asked specifically to talk about what's been the main evolution in terms of guidance provided to countries around Article 19, so really community inclusion. And I'd like to start by saying that WHO has been advocating for deinstitutionalization and community inclusion for the last 15 years. And WHO laid out very clear policy recommendations in the World Health Report in 2001. And this has been reinforced more recently with the Comprehensive Mental Health Action Plan in 2013. And these policy directions or recommendations were to close down psychiatric institutions, to integrate mental health into general healthcare services, and also to develop a full range of community-based mental health services. However, there definitely has been an evolution from 15 years ago until now in terms of the guidance that WHO is providing countries, specifically in relation to Article 19. And this is really in terms of how community mental health services are defined, and also in terms of what community mental health services should be delivering. So the CRPD has really opened up new ways of thinking about and conceptualizing community mental health services. That's for sure. And this has really influenced our work at WHO through the Quality Rights Initiative. And we'll be having a workshop on the Quality Rights Initiative later on in the afternoon. So traditionally, by community mental health services, WHO has meant services like mental health outpatient clinics, mental health units in general hospitals, residential services, halfway houses, and delivering mental health treatment and care through primary health care. So this is how WHO has traditionally referred to community-based mental health services. However, what's clear is that community mental health services need to be more than mental health services which are purely based or situated in the community. It's really, the key point is that the mental health services, community-based mental health services, need to be actively promoting community inclusion. And that's the key, and independent living. And the types of traditional services, community mental health services that I mentioned earlier, are simply not doing this. A lot of them aren't, some maybe. So the community-based services that we're advocating for through Quality Rights need to be based on the social and human rights models of disabilities as opposed to the traditional biomedical model. We are emphasizing the need to adopt a recovery approach in services where people feel empowered and supported to take control of their identity and their lives, have hope for their life, and live a life that has meaning for them. And that may be whether it's through work, through relationships, through community integration, through some of these, or through all of these. We are now providing guidance and recommendations to countries based on these concepts and also on Article 19 in order to ensure that people have choice in terms of where and with whom people want to live. And also, in second, that people have access to the full range of support and services to enable them to live in their own chosen community. And, you know, none of the articles of the CRPD can be realised on their own. So the articles around community inclusion really highlight the importance of the full realisation of Article 12 on legal capacity. So some of the examples of emerging services from different countries which we believe are important and which we are promoting in our discussions with countries include open dialogue approach in Lapland and Finland, the personal ombudsman system in Sweden, circle of support, and a whole variety of different forms of peer support which are emerging in countries, both one-to-one peer support, group peer support, based in services and based in the community. And we do also, and I think this was mentioned quite a lot in the previous day's discussions, peer support is at its best when it's being delivered by an independent peer organisation, and particularly when it's being provided in the mental health services, because we do see already in countries that peer support workers are becoming part of the traditional system. And actually starting to get into a sort of, starting to protect the particular practices which are happening in the traditional mental health services and find justifications and excuses for why they're happening. So this idea of independence, the role of independent organisations in providing peer support is a really important one. So these are some of the services that we're starting to discuss and have a dialogue with countries about, and what's common to all these services and what makes them successful is the respect for legal capacity, support and not control, and also the focus on community inclusion. And I'm sure, and I've even heard throughout the days of this conference, there are so many other types of services which are being delivered in different countries that we haven't even heard about. So next year through Quality Rights Initiative, we're putting together a best practice document on CRPD compliant community-based services. And in order to make sure that we're able to identify things that are happening in the communities and aren't just published, we're going to be doing sort of a global e-consultation to get as much information from around the world and from local communities to make sure that we're bringing to the table many of the different good practices that are happening that we don't know about. So these are the new directions for community mental health services and supports for adults that we are urging countries to develop as part of their obligations to implement the CRPD. And this brings me to my last point, which is that we should not forget children with disabilities, particularly those living in institutions, and I haven't heard a lot of discussion about that at this conference. The consequences of institutionalization on children's mental and physical health is catastrophic. It leads, there's a lot of evidence that institutions lead to early harm to early brain development and also to death. So we really need to do whatever we can to make sure we get children out of institutions and stop them from going into institutions. And so in the context of children and families, we also very much need to be promoting Article 19 of the CRPD. We need to be promoting early childhood interventions for very young children with disabilities. And there's a large evidence base that this is hugely successful in both low, middle and high income countries. We also need to be providing widespread parenting programs to provide parents with the skills on how to provide a stimulating and emotionally supportive environment for children with disabilities, for their children. We need to look at providing more respite services because they're crucially important in allowing parents and children to take a break from each other. And of course, we need to be looking at foster care and small group homes where children are not able to live in their families. By small group homes, I'm not talking about mini institutions in the community. We're really talking about small groups of children living in family environments which are really well integrated into the community. And of course, all these services need to be provided within a backdrop of inclusive education systems and financial assistance to families. And all of this is going to be central to ensuring that children stay out of institutions, stay with their families, and have prospects for a better future in the community. I want to end by saying that there's been a long history of inaction when it comes to human rights issues in mental health. At the same time, there is a growing consensus that there is so much that we can do to move forward. So human rights should not be the exception. It needs to become mainstream. It needs to become the standard for training, for service provision, for policy, and for law. And this is what we are trying to achieve through our WHO Quality Rights Initiative, and I hope to see some of you in the afternoon's workshop when we can describe a little bit more about what we're doing on the ground to change attitudes and practices, as well as some of our plans for future work. We see a role to engage everyone, civil society groups, and we have already, and we've hugely benefited from the inputs of civil society, human rights advocates, really open-minded mental health professionals, because I firmly believe that if we do form close alliances, also amongst all the organizations at international level, we have a huge opportunity at the moment with this renewed interest in mental health. We have a huge opportunity to make important changes in the field that we all want to see. We can, I think, end coercion, violence and abuse. We can promote legal capacity. There are good practices out there, and we can expand on these good practices and make them known to more people, more the different groups, professionals, civil society, families, and countries as well. Thank you very much.